I'm Dr. JP, ER doctor, toxicologist, and unapologetic lover of all things poison. Want to know how someone goes from completely normal to unconscious in minutes with nothing around them? What drug was deemed too dangerous for medical use but is now a drug of abuse? What new way contraband is being smuggled into prisons? Stay right here to find out. This is an interactive story. Will our patient live or die? It's up to you and the choices you make. Today's episode starts in a prison. You've agreed, somewhat reluctantly, to accompany a friend. She runs a nonprofit that teaches inmates to write and tell their stories. Today, you're one of the volunteers. You sit in a large concrete block room, painted gray, with rows of tables, scattered pencils, and stacks of paper. It almost feels like a school until the warden walks in. He thanks you for volunteering and says the prison is a dangerous place and they can't guarantee your safety around violent felons. He says if anybody wants to leave, now is the time. You seriously consider it. As an ER doctor, you know full well the extent of violence that can happen inside of a prison: broken bones, dislocations, stab wounds. In many prisons, trauma is the #1 cause of medical problems. Your friend glances at you. She gives you a small smile and a subtle shake of her head. You give her a look, but you stay. The inmates file in. For the next hour, the group discusses writing, journaling, and storytelling. When you break down into small groups, your inmate partner tells you the story of his life, how he ended up in jail, and his dreams after release in a few years. At the end of the session, the inmates are taken back to their cells. You, your friend, and the other volunteers strategize about future directions given how well it went while cleaning up. Then, an alarm sounds. The guard stiffens, his radio squawks. He says, "Medical issue, stay here, I'll escort you out afterward." You tell him you're an ER doctor and ask if they need help. Of course, in real life, the prison has its own medical staff, but this is fiction, so he waits for you to come with him. You follow him down one gray hallway after another until you reach an open cell door. Your partner is inside, unconscious and slumped over the toilet. You scan the room. There's not much to see: 2 bunk beds bolted to the wall and a fixed steel toilet. There's no food, no powder, no weapons, just some loose pieces of paper scattered on the floor, some with writing from the story he was working on today. 10 minutes ago, he was awake and talking to you. Now he's unresponsive. The guards handcuff him even though he's completely unresponsive, scoop him up, and transport him to the emergency department. This is fiction, so you guessed it, you're the ER doctor. You have to figure out what happened to your partner and how he collapsed in minutes inside an empty cell. What happened in there? The nurses cut off his orange jumpsuit, hook him up to the monitor, and obtain IV access. Noticing that he's turning blue and barely breathing, the intern applies a bag valve mask to his face and starts bagging. The nurses get vitals. They're as follows. His temperature is normal, 98.6 or 37. He has a heart rate of 80 beats per minute, a blood pressure of 110/60, a respiratory rate of 2, and an oxygen saturation of 80% on room air. Question number 1. As we move on to the physical exam, what finding will be helpful to tell us if a classic poisoning toxidrome is present? Is it A, pupils, B, lung sounds, C, a rash, or D, muscle tone? The answer here is A, pupils. Of course, we want a thorough physical exam and we want all of that information. But in a patient with an altered mental status and a low respiratory rate, I want to know immediately about the pupils to decide if this is a classic opioid toxidrome. The intern opens his eyelids, shines a light back and forth, and says pupils are normal and reactive. As for the rest of his exam, he's completely unresponsive, including to pain. His heart and lungs sound normal. His abdomen is soft and non-distended. He's currently not moving any of his extremities. His skin is warm and dry without a rash. If you've listened to prior episodes, you know that this is not a classic opioid toxidrome. He certainly has the altered mental status and the depressed breathing, but he should have pinpoint pupils. His oxygen saturation has improved, now in the low 90s, thanks to the oxygen and the bag valve mask ventilation helping him to breathe. Question number 2. What is the next step? Is it A, intubation, B, physostigmine, or C, naloxone, i.e. Narcan? The answer is C, naloxone, though if you said intubation, you're definitely not wrong. As we've discussed on prior episodes, naloxone is the antidote for opioid overdoses like fentanyl and heroin. The indications for giving it are a respiratory rate of less than 8. Yes, I did say he's missing the third part of the opioid toxidrome, so if you think intubation is safer, I won't say you're wrong. However, the pupil exam, like everything else in medicine, is never 100%. What we know is that he had a sudden collapse in minutes. We know he has a depressed mental status and a depressed respiratory rate, all consistent with opioids, so I personally would try a dose of Narcan before intubation. You ask the intern what dose to give. She says, start low and go slow, right? To avoid withdrawal. You nod in agreement. 0.5 milligrams, she says. The nurse draws it up and administers it. Nothing happens. Now what, you ask her? Well, he's still not breathing, but he's also not showing any signs of opioid withdrawal, so I think it's safe to give a bigger dose, she says, and tells the nurse to give a milligram. This time, his breathing increases from 2 breaths to 4, so she orders a third bigger dose and he starts to move spontaneously. She takes off the bag valve mask as his respirations come up to 8 and his pulse ox stays at 93% on room air. He's stable, at least for the moment, so you and the intern go to your desk to discuss the case further. She says, well, it must be an opioid overdose because it responded to Narcan. It's weird that he didn't have pinpoint pupils, though. You agree, saying the patients don't always read the textbooks, meaning they don't always follow the rules exactly. She says, how did he overdose on opioids? I thought you said he was in prison. Unfortunately, there are a lot of drugs inside prisons. Being incarcerated doesn't mean you can't take illicit substances. She orders some basic labs, a urine drug screen, and a chest x-ray to make sure it wasn't anything else, all of which come back normal an hour later. She says, what do you think happened? You say, what do you mean? We just talked about opioid overdoses. And she says, but his urine drug screen came back negative. Also, I went in there to check on him a few minutes ago to see if he needed more naloxone, and the prison guard asked me what happened. Wouldn't they have found the drugs? I hope you didn't say anything, you respond. The prison guard doesn't have any legal right to know his medical history. No, don't worry, she says. I didn't tell him anything. But he asked because guards searched our patient's cell from top to bottom and didn't find any contraband. No drugs, nothing. You ask, what does the urine drug screen test for? She says, it tests for naturally occurring opioids like morphine and codeine found inside poppy plants. It doesn't test at all for synthetic opioids like fentanyl or methadone. And it has about a 50% sensitivity, so it's flipping a coin as to whether or not the test will be positive for things like oxycodone and hydrocodone, i.e. Vicodin and Percocet. Meaning there are plenty of opioids it can miss, she says. Exactly. We toxicologists seem to be the only people who don't love urine drug screens. And who knows about the contraband inside his cell? It's certainly not the first time the guards have been outwitted by an inmate, or maybe he just took the last dose and there's nothing left to find. It's unclear how these facts are relevant at this moment in time for our patient's treatment. Anyway, you tell her to watch the patient for 6 hours after the last dose of naloxone because you don't know what he took and you don't know if it's a long-acting opioid. This is a fairly standard observation period to see if somebody requires additional doses of naloxone. Eventually, the patient wakes up, has a meal, tells you the hospital food is better than the prison food, and is discharged uneventfully. But that's not the end of the story. 1 month later, you go back to the prison, returning with your friend and her nonprofit for more journaling and storytelling. Things this time are a little different. Your friend hasn't brought paper, journals, pens, pencils, or markers. She says the prison rules have changed due to some unusual circumstances. Which of the following have been recently banned in prisons around the world? That's question number 3. Is it A, pens, B, pencils, C, paper, or D, markers? You wonder if the prisoners have been eating the pens and pencils. Think that's crazy? It's not. Prison is a difficult place filled with difficult people, and for reasons of secondary gain, some prisoners prefer to be in the hospital as it's a safer and less difficult place. This means sometimes they intentionally swallow pens and pencils in order to be brought to the hospital. In other cases, prisoners swallow them due to severe psychiatric illness. I know the gastroenterologists listening have probably all removed 4 or 5 pens or pencils from a patient's stomach after the patient swallowed them whole. No, it's not the pens and pencils, your friend says. She has iPads for the patients to use instead. The answer is C, paper. Why? Excellent question. Earlier, you told the intern it was easy to get illicit drugs in prison, so let's talk about how these substances get into prisons. I think everybody knows that most prisoners get a body cavity search to look for concealment of illicit substances in places like the rectum or vagina. We've talked before about swallowing drugs for the purposes of concealment, i.e. body stuffers and body packers. People do this to smuggle them into prison, not just to smuggle them into a different country. I'll tell you a funny story from residency. I was training at a level 1 trauma center and I was on the trauma team along with the orthopedic intern. 2 patients were brought in under arrest by police after a rollover motor vehicle crash. As you're well aware, one of the first things we do is cut off the clothes and do a full physical exam to look for potential injuries. In this case, a full physical exam includes a rectal exam, i.e. a finger in the rectum to check for rectal tone. Usually when you put your finger in somebody's rectum, their sphincter clamps down, meaning their spinal cord is working normally. If you put your finger in and nothing happens, this actually is a significant concern for spinal cord injury and directs you towards further imaging for evaluation. Not surprisingly, the rectal exam is the intern's job. I did the rectal exam on my patient, noting normal rectal tone. I also felt a foreign body and pulled out a plastic baggie with white powder, i.e. some kind of drugs. The 2 patients were evaluated, didn't have any significant injuries, and both were discharged to jail. A few hours later, I was telling the orthopedic intern about the drugs, and I said, yeah, when I put my finger in there was a plastic bag, so I pulled it out. A funny look passed over her face, and she said, oh. After a few seconds, she said, oh, I felt something weird in there on my patient too, but I didn't know what it was. One of the 2 patients was discharged from the emergency department with the internal concealment intact. I've always wondered if it got through into the jail or if it was discovered on a body cavity search. Anyway, in order to get around well-known methods of smuggling drugs into jail, inmates, family, and friends are always trying to come up with other more creative methods. I'm sure you've seen in the movies where people pass plastic bags or balloons filled with drugs over a kiss, via a handshake, or concealed in food and drinks. I saw a case in the news recently where tragically a little baby was used to pass the drugs hidden in his diaper. Sometimes it's as easy as bribing the staff to allow drugs in, along with shipments of food or equipment. Drones have been used to try to drop packages into an exercise yard. Drugs have been concealed inside tennis balls or dead animals and then thrown over the fence for an inmate to pick up. There's one pretty ingenious way that's been increasing in popularity recently. You may have heard about it on the news. And I should add also that the toxicity of the drugs concealed on them is also increasing in toxicity. The method of concealment is putting the drugs onto paper and smuggling the paper into prison. This isn't new. Think about LSD or acid. It's been put on blotter paper since the 1970s. Essentially, liquid LSD is put onto absorbent paper. Users put a small piece in their mouth. The paper dissolves. The LSD is released and gets absorbed. I didn't actually know until I did this podcast that putting the LSD on paper was in response to evading law enforcement. After LSD was criminalized in the 1960s in the US, penalties were related to the weight of the drug, and blotter paper was light and easy to hide. But it's not just LSD that's been put on paper, but just about every other drug you can think of, including meth, fentanyl, and cocaine. Why? Because prisoners, of course, are allowed to receive letters. They're allowed to have books also. Smuggling became even more sophisticated when people mailing drugs inside prisons posed as Amazon resellers, sending books to prisoners with pages of the books coded in drugs. I said earlier that drugs are pretty easy to come by in prison, but what they definitely aren't is cheap. You can imagine smuggling increases the cost of these already illicit drugs. One source I saw said a 12 by 12 piece of paper covered with drugs could be worth as much as $10,000 inside. It's a lot of money and it's a lot of incentive. The prisoners file in, you're paired with the same partner as before. He sits down and picks up an iPad. You ask how he's feeling. He says he's doing great and can't wait to continue to share a story. He picks up the stylus and starts writing. The person sitting on the other side of you asks a question. As you finish answering, you look back towards your partner and see him slip a tiny piece of paper into his mouth. A few minutes later, his eyelids drift down and he stops writing on the iPad. Uh-oh, I think you just figured out what happened to him last time. You look at the prison guard wondering what to do next. You don't want your partner to have another life-threatening overdose, but you have no idea what kind of trouble he'll get into if you report this to the authorities. You keep a close watch on his breathing for another few minutes, but then he slumps over the table, attracting the guard's attention. The guard can't wake him up, and your partner's breathing gets slower. Probably paper again, the guard mutters. This time your partner is taken to the prison medical area for further observation. All right, so let's talk first about what's been smuggled in on paper, and then we'll talk specifically about what's happened to your partner. Looking up some facts, I was absolutely astonished to see what the #1 contraband drug in U.S. prisons from the years between 2019 to 2023. Can you guess? That's question number 4. Is it A, fentanyl, B, marijuana, C, methamphetamine, or D, buprenorphine? To my surprise, the answer is actually D, buprenorphine. I for sure would not have gotten this one correct. And this is according to a U.S. Sentencing Commission fact sheet on prison contraband. Buprenorphine is an opioid, but it's a partial agonist, meaning we use it to treat opioid withdrawal much more often than it's used as a drug of abuse. I'm not at all surprised people inside prison are having opioid withdrawal. We use buprenorphine very commonly in the emergency department and in psychiatry to treat opioid use disorders and withdrawal, so I'm honestly surprised it's actually contraband and not something you could get anyway inside the prison as a prescription. I don't know, maybe somebody listening who knows more about this than me can tell us. The most common contraband inside U.S. prisons are first cell phones, then drugs, then weapons. The consequences for getting caught with drugs as contraband are significant, with individuals receiving an average of 16 months in prison. Just how common is drug use inside prisons? Well, one study suggested about 30% of incarcerated people were using drugs, with a range from 3% to an astonishing 90%, depending on the prison. Let's get back to specifically what's being smuggled in on paper. As I said, it could be anything, but what's often being smuggled these days are what we call novel psychoactive substances. What does that mean? These are synthesized variations on typical drugs of abuse. For example, you've probably heard of K2, essentially a synthetic derivative of marijuana. There are synthetic opioids and benzodiazepines as well. Why bother with all of these? First of all, these drugs may not be illegal because they're new and not scheduled under existing laws, so penalties may be less. Second, they often don't make the urine drug screen turn positive. We've talked about its weaknesses. And third, the novel psychoactive substances can be highly concentrated and very potent, making them smaller and easier to smuggle. Oftentimes, they're also very cheap to manufacture. Drug-laced paper has become such a significant problem that in many prisons, including US, Germany, and Scotland, mail is photocopied and the prisoners actually get the photocopy rather than the original paper in case the original was impregnated with drugs. Interestingly, it's reported that this photocopying method has reduced drug-related incidents in Scottish prisons by almost 60%. It's pretty amazing. The warden comes in and tells you they're monitoring your partner in the medical ward and tells you what you've already concluded, that his overdose last month was due to drug-laced paper. The warden says they sent the paper off for analysis and it recently came back as impregnated. Now, this is a super tough one because it's a very novel psychoactive substance, but it's question number 5 and it's time to pick your poison. Was your partner's paper impregnated with A. Medetomidine, B. Isonitazine, C. JWH 0118? The answer is B. Isonitazine. Medetomidine is a contaminant in opioids. We talked about this in a prior episode. It can cause low heart rate and can cause significant withdrawal symptoms with high blood pressure. JWH 018 is a synthetic cannabinoid. Isonitazine, or ISO as it's often called, is in a category of drugs called nitazines. There are more than 40 different kinds. Most of them are more potent than fentanyl. Isonitazine specifically is about 250 to 900 times stronger than morphine, and to compare, fentanyl is about 25 to 50 times stronger than morphine. Some nitazines are even more potent. They can be taken any way that your typical opioids are taken: injected, inhaled, snorted, or vaped. Nitazines were developed in the 1950s by researchers in Switzerland as an alternative to morphine, but they were never actually used in medical practice. I love this due to a, quote, unfavorable balance between therapeutic and toxic effects, end quote. There was a high risk of depression and addiction. The different compounds vary in potency, side effects, and half-life. What do? Well, they're opioid receptor agonists like fentanyl and morphine, so they can cause altered mental status, respiratory depression, respiratory arrest, and death. Interestingly, it's about 50-50 whether they cause constricted pupils, like the classic opioid toxidrome we were talking about in the beginning. Other side effects of depressed respiration include aspiration pneumonitis, ventricular tachycardia, and heart attacks from low blood oxygen. As it was with your writing partner, naloxone is effective and would be the treatment of choice. Intubation and ventilation will work just as well, so you can breathe for them until the drug wears off. Sometimes patients do require additional doses of naloxone, other times they don't. This probably has to do with which specific drug they've been exposed to and the dose of the drug. Of course, at the bedside in the emergency department, we'll never know what that was or how much they took. Essentially, you continue to monitor for clinical symptoms, and that'll determine the need for more antidote or not. Nitazines had essentially faded into obscurity after the 1950s, until 1998 when they popped up as a drug of abuse. 10 deaths occurred in Moscow due to nitazine. This was followed by a chemist manufacturing it in Utah in 2003. Apparently, he manufactured it for himself, converted it into a liquid form, and then used a nasal spray bottle to administer it. He was caught by law enforcement, and sadly, he committed suicide before he was brought to trial. 2019 is when nitazines became much more widespread. As with many drug analogs, the legal status is really variable. In the US, Canada, and the UK, most of them are Schedule 1 or Schedule A, the highest level of restriction. I think we're going to see a lot more cases of nitazene toxicity in the US because they're becoming increasingly popular worldwide. Sometimes patients take them intentionally, as with the chemist, but other times the exposure is accidental. You never know what you're actually getting with illicit drugs. Interestingly enough, in Australia, nitazene analogs are now more common than fentanyl. Some cases of nitazene poisoning occurred in Australia after people vaped what they believed to be cannabis. In the UK, people believed they were taking MDMA, i.e. ecstasy or Molly, and in fact took tablets containing nitazene instead. So back to our patient. You're unable to attend the following month's writing session thanks to a shift. Your friend inquires about your writing partner, telling you he was observed in the prison medical unit, but this time didn't require naloxone or transfer to the hospital. He may, however, get additional jail time for charges related to possession of contraband. The prison continues to track down on paper to try to reduce poisoning and overdose deaths inside. This is a fictional case, as are all our cases, to protect the innocent, but it is based on real poisonings. And that brings us to the last question in today's podcast. In U.S. prisons, there are 3 main types of contraband, as I said earlier: drugs, weapons, and cell phones. Weapons are usually manufactured inside the prison by inmates, not surprisingly. Drugs and cell phones are generally smuggled in from the outside. One more commonly by corrections officers and one more commonly by visitors. Which is more commonly smuggled in by corrections officers? A, drugs, or B, cell phones? Follow the X and Instagram feeds, both at PickPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Until next time, take care and stay safe.